You're most welcome to this talk. Now, I've had so many questions about the safety of vaccines, so we're going to look at that now. And as well as looking at the safety of vaccines, I'm going to look at the probability, I think we could say probability, that we're going to require a third vaccination next autumn or winter, at least in the UK. And we'll also be looking at a curious finding which may or may not be correct. It's looking like it might be correct. And that is that vaccination seems to relieve the symptoms of what is called long COVID syndrome. So we'll look at those today. And if we get time, we'll look at COVID tongue as well. This new phenomena that's been identified of COVID tongue seems to be more of a problem in severe cases rather than mild cases, but probably tells us something about the disease, which is interesting. Now, straight on with the vaccine safety issue. The people that are most opinionated, of course, are those that are most likely to leave comments on my videos or email me. So I would encourage the vast majority of us that are reasonable and sensible just to leave comments as well, so it kind of balances out a bit. But apparently I'm paid huge amounts of money by big pharmaceutical companies to say what I say. Well, let me give you my personal guarantee. I am not paid anything by any pharmaceutical companies at all. They make me an offer in future, I'll think about it, but as of now, I am not. It's a serious point. What I try and do is look at the data and work out what is best for most people. Therapeutics are great. I wish we had more focus on therapeutics, not knocking that, but vaccination is efficacious, and I've seen it save many, many lives in other circumstances. All the other diseases we vaccinate against that are quite horrible. Anyway, getting down to the main point, AstraZeneca vaccine. This is their press release yesterday. That they claim the vaccine is safe, but we'll be looking at why they claim that and testing that claim. 17 million people vaccinated in the European Union and UK with COVID-19 vaccine AstraZeneca. I think most of these in the UK, I think there are about 11 million of these have been given out in the UK now. So the majority is in the UK, but still a substantial number throughout Europe. And AstraZeneca is saying there's no increase in incidence of blood clots in any defined age group, gender, batch of their vaccine, or any particular country. So what they're saying here is they've taken into account, is there a particular problem in a particular age group? They have no data to suggest that. Is there a particular problem male-female? They have no reason to suggest that. Is there a particular bad batch? Their data gives them no reason to suggest there's been a bad batch. And there's no reason to suspect there's a problem in any particular country. So the monitoring is very studious from the company itself, and of course monitoring is also carried out by the European Medicines Agency, the authorities in the UK, and indeed the World Health Organization. So 18th of March, they said 15 events of deep venous thrombosis and 22 events of pulmonary embolism. Now, I think I'll just tell you briefly what that is. So what we have is imagine that these are the veins in the legs here. So these are veins in the legs, and they join up to form larger veins. They're like that. So they'll join up to form a larger vein there called the femoral vein at the top of the leg, and that joins with the femoral vein from the other side of the body there, and that goes up into a large blood vessel called the inferior vena cava, and that basically takes blood back to the right side of the heart. So if we imagine that this is the right side of the heart here, and it's in two chambers. So the blood goes into the right atrium through to the right ventricle, and the right ventricle is pumping blood out into the pulmonary circulation. So there's one large pulmonary artery leaves the right ventricle. So the blood here has come back from the body. It's gone into the right atrium, through to the right ventricle, and out in this pulmonary artery, which takes blood to the lungs. And of course that quickly divides into two because we've got two lungs. And then as the blood vessels, as the arteries take the blood out to the smaller areas of the lungs, of course the vessels get smaller. The pulmonary arterial tree gets progressively smaller and eventually goes down to the pulmonary capillaries. And then a pulmonary capillary, so if we have a pulmonary capillary here, imagine that's a pulmonary capillary. a pulmonary arteriole rather. Pulmonary arteriole will break down into numerous pulmonary capillaries like this. So there'll be a network of pulmonary capillaries, and then these will take blood to the into a pulmonary venule, and that will take blood back to the left side of the heart to go back to the body. And of course, these surround the alveoli, which are these air sacs that we've looked at many times. So that's the way it works. Now the problem is with if you have a deep venous thrombosis in one of the veins of the leg here. So suppose you have it's called a DVT, deep venous thrombosis. You get a blood clot there where there's not supposed to be one. So that will be a thrombus. And it's in a deep vein, so it's a deep venous thrombosis. Now, if a bit of that breaks off, and this happens, then there's a bit there broken off, you see. Then it's not too much of a problem because it's going into a bigger vessel, then that goes into a bigger vessel. And the thrombus, when the thrombosis moves, it's called an embolism or an embolus. Embolism is the name of the condition. So that would be an embolus, several emboli. And then it goes back, and of course, as the vessels get towards the heart, they get bigger and bigger. And then the right atrium is quite big and the right ventricle is quite big. So the blood goes into there and then it gets pumped out into the artery, which is also big. Now, if it's a huge embolism, it will block there. But typically what happens is it blocks when it gets to the vessels which are too small to allow it through. And these are called pulmonary embolism because they're in the lungs. So this is a PE, a pulmonary embolism. Pulmonary embolism. So what we find is that DVT causes PE. So that is the main problem here that we're describing with the blood clotting. So that's kind of the pathology really of what people are worried about. Anyway, getting back to the data. So, as we said, 8th of March, data from the 8th of March, up to then there have been 15 events of DVT and 22 events of pulmonary embolism. Sometimes we call this VTE, venothromboembolism, because it describes both conditions. So the risk of a DVT, I mean, it's bad because it gives you a sore leg, but it's really dangerous because it can cause blood clots in the lungs. That's why it's a problem. But these numbers of events are much lower than would be expected to occur naturally in the given population, according to the AstraZeneca data. In clinical trials, numbers of thrombotic events were small, lower than in the vaccinated group. So they were lower in the vaccinated group, lower in the vaccinated group. So this is indicating that the vaccine, if anything, doesn't actually say this, but it indicates the vaccine could be having a protective effect against blood clots. No evidence of increased bleeding over 60,000 participants. Because the other thing that was talked about, I think it was someone from Denmark, that the blood was actually not clotting, a condition where there wasn't enough thrombocytes in the blood, causing blood clotting, the platelets in the blood. And the company also said, direct quote, there are also no confirmed issues related to any batch of our vaccine used across Europe or the rest of the world, is what they are saying. And to be fair, this is public domain data. You know, people check this data. There's quality testing. 60 quality tests are conducted by the company on the vaccines, 20 independent testing laboratories. So I guess this is why they're happy that the batches are okay. Now, we did look at the incidence of blood clots just a few days ago on videos. And the incident rate in most European countries and the United States, men get about 130 per 100,000 of the population per year. Women get there's about 120 cases per 100,000 of the population a year. So that works out at about 120 people per 100,000 per year. So that means that in a city of 100,000 people, you'd expect about 120. In a city of 120,000 people, a city of 100,000 people, sorry, you'd expect about 120 cases. So this is common. We see this common in clinical practice. Anyway, that works out at 10 per month per 100,000. That's 120 per million per month. And the data I originally had when I did this calculation was on 3 million vaccines. So we'd expect 360 thromboembolic events expected per month. These are common. And yet the data here is that they have 15 events of DVT and 22 events, so that's 37 events or something, from a much larger population size. So while of course it's right to look at this, the data doesn't actually seem to be surprising. I mean, it's bad that these individuals have got this, but this happens all the time anyway. We just learned on the last video that Greg Hunt, I think is he the health minister in Australia? Anyway, he had his vaccine one day and he was admitted to hospital the next day with a completely separate condition called cellulitis. You know, the fact of the matter is people do get sick. So from these numbers that are available in the public domain, from what I have in front of me, it really is hard for me to understand why so many countries have suspended the Oxford AstraZeneca vaccine. It's a little bit hard to understand. And but what is clear is that the suspension of the vaccine will lead to delay in the vaccination programme, and I think we all know what that implies. Now, moving on to this idea of a third vaccine, a third UK injection. This has been a few popular news reports. And pensioners, older people, are probably going to get a booster of the COVID injection. That is, let's be clear, that's the third injection in autumn, perhaps August or September time. Waiting till winter could be too late because we know we have this delay effect on the vaccine taking effect to generate its immunological effect. So they're now talking about this in August or September, a third vaccine. So this is this professor, Joint Committee on Vaccination and Immunisation. Top-up would be needed to protect against new variants potentially, or as a safety net. So the thing is, at the moment, we don't know how long the immunity from the vaccine is going to last. I think the signs so far are pretty hopeful, but we simply don't know. So would it be safer to vaccinate high-risk people just in case the vaccine runs out in January? Well, that seems to be the thinking. And vaccines, of course, will be tailored. Vaccines are being designed now which are tailored to the new variant. The UK variant, the South Africa variant, the Brazil variant. It's not too hard to tweak the vaccines for these new variants. So it would be a more specific vaccine, and it would be prolonging the longevity of the immune response should that be necessary, because the duration is unknown. Third possible way of affecting the vulnerable next winter is the risk. So this is a direct quote from this professor, from Professor Harden. This is the risk. So the numbers in the UK are going down now, but could they increase again next winter is the concern. And we have said that it is probably going to take a few seasons. Again, two views on this. My view remains that in a few seasons' time we can eradicate this infection. Others think it will become endemic. But for the next few seasons we are going to get We're going to get increases of COVID cases over winter, I would expect. Annual COVID-19 vaccinations could be necessary in the years to come. Possibly, let's hope for not too many years, but possibly. Or not if immunity lasts for a long time. We don't know. I am hopeful that the immune response will last for some time, based on the SARS coronavirus 1 information we have from 2003. Now, interesting here, long COVID. Now, we have looked at long COVID before. So early data indicating that vaccine could be beneficial in long COVID. So vaccines may alleviate the symptoms of long COVID. Now, this is anecdotal so far. It's come from patient groups and it's come from scientists. And it's what appears to be the case. It's anecdotal. So we're not talking about firm data yet. But it is looking interesting and encouraging, it has to be said. Now, background here is about 10% of people who get COVID-19 suffer symptoms for 12 weeks, about 10% for 12 weeks. And a significant percentage, we don't know, 2, 3, 4%, we don't know, have symptoms for longer than that, this long COVID. So it seems that when people with long COVID get vaccinated, there's a 20 to 50% of these people get reduced symptoms, like reduced fatigue, reduced headache, reduced brain fog. But the effect does appear to be temporary, unfortunately, but they do seem to get a few weeks off their symptoms. More on long COVID in a minute. Dr. David Strawn, University of Exeter, he says this. He runs long COVID clinics, member of the NHS Long COVID Task Force, so he's one of the national experts. We're getting people reporting improvements, and it's quite widespread, about half of the people we're asking. So that sounds good. But there's a major reporting bias because the people that are feeling better start bouncing up and down about it and want to shout about it. So there's a reporting bias there, but it's still an interesting finding. This provides a bit of hope for people who've been struggling with this for 12 months or so, just to feel a bit better, at least for a while. So it's good. It's good for these individuals. They're kind of getting a break from their long COVID, really. A few weeks break as a result of the vaccination. But perhaps the more important point is it's telling us, or it's food for research to look at what might be going on here. Because if you look at the effect of a therapeutic, that can tell you a lot about the cause of the disease. So if someone has a particular type of infection and you give them an antibiotic and they respond, then it could well be a form of bacterial infection. If they don't respond, it could be a form of viral infection. So the way people respond to treatments can actually tell us quite a lot about the nature of the disease itself. Or if someone's got a pain in their chest, we give them some glycerine trinitrate under the tongue very often. If that pain then goes away, then it indicates that that pain could be angina. This is a standard thing we do. We put sprays of glycerine trinitrate under the tongue. If the patient's pain goes away almost straight away, it indicates it could be a cardiac pain. So the way people respond to treatment is a very standard way of learning about disease. So this is what he's saying here, but also as researchers, it tells a lot of information. Does this give clues about what we should, about how we should be treating it and what we need to be looking at? Basically, is what he's saying. So it's a way into studying it. Lou Barnes coordinates 4,000 strong post-COVID symptom group. She estimates the improvements nearer 20% from her 4,000 members. Improvement, she believes, lasting for around 3 weeks. But others reported feeling worse for a short time, which of course doesn't surprise me at all, because these are people that have had COVID-19, and it's not surprising that they feel worse after the injection because of the immunological response. We know this from healthcare providers, that if they've had the infection before, that they are more likely to feel ill for a short period of time after the vaccine. I've talked to many people who've experienced exactly that for a short time. So it's not surprising that some get ill, but it's or unwell for a few days. But the improvement lasting around 3 weeks in some percentage is interesting and encouraging. Immunological opinion. It's very interesting because we still have no clue about the mechanisms of long COVID. Dear me. We are in the early stages of research into this and what to do for our patients. And also because many sufferers are anxious about their immune status. This has led to some paradoxical vaccine hesitancy. So this is looking good news for vaccination for people with long COVID, that the vaccine is having a beneficial effect, at least in the short term. And I'm trying to focus on what I'm saying now, because my mind is sort of whirring around other implications of what this could mean, and how that would relate to the cause of the possible immunological inflammatory causes of long COVID, at least in some people. Professor Eleanor Riley, another immunologist, one of the hypotheses about chronic fatigue syndrome is that it's a failure of the immune system to reset after viral infection. So it's like the immune system still stays in infection fighting mode, is kind of what this thinking would say. And if that's the case, then giving the immune system a bit of a jolt her words, not mine, for example, by vaccination may help to reset. So yeah, I mean, it's giving the immune system something to do as it fights as it combats, but produces an immunological response to the antigen. But she's not sure. It's possible it may turn out to be random. Doesn't look like it's random. I think there is something here. And of course, there's probably two forms of long COVID. This is me talking again. So after severe cases, we've known a long time that anyone basically who's very ill, for example, people that go to intensive care get post-intensive care syndromes, regardless of why they go to intensive care. So there's probably people that have been very ill, therefore have long-term consequences as a result of that. And there's probably others who've often had milder disease who get this query immunological reaction. Is it caused by this failure of the immune system to reset? So there's probably two groups there. The severe ones could have a level of organ damage. These ones, it seems to be more a physiological type of process that's going on. A lot more research to come on that, and is being done at the moment. Studies are carrying on as we speak. But interesting, and very often answers to these questions just come along serendipitously. An observation is made, and of course, fortune favours the prepared mind. In the minds of immunologists who know about these things, they'll say, "Oh, that happened. Ooh." And then they'll kind of work out clever things from there. It's often how progress is made. Now, I'm going to finish briefly on COVID tongue. Now, it's not the best picture in the world from the COVID symptom tracker app, but what seems to happen if you get these kind of these it's not a good picture at all, but you get these kind of white bits and these reddish inflamed bits in it. This phenomena which appears to be related to COVID. So let's have a quick look at that. It is quite intriguing. The COVID symptom tracker app, of course, a lot of people reporting in to this, and new symptoms have been discovered in this way. So previous reported mouth and tongue changes have been reported. Dry mouth, loss of taste, and fungal infections, of course, are really common anyway. We treat loads of these with normally nystatin antifungal mouthwash type things. It's like drops you put in your mouth and swill it round. Reports in changes in tongue sensation, muscle pain while chewing, swelling of the mouth, ulcers of the tongue or inner surface of the mouth and lips have been reported previously in previous research into this. So reporters asked to identify new features on the COVID symptom tracker app. I'm a reporter. Anyone who reports into it is such a person, and that's how we've learned largely about, or certainly quantified, loss of smell, skin rashes, and the confusion, the acute confusion that can occur, especially in elderly people with COVID. Tongue doesn't look normal, white and patchy in long COVID, not long COVID, COVID tongue, I'm still on the last article. COVID tongue is what to look out for, or indeed any other changes, because we're still understanding the clinical syndrome that is COVID. So what causes COVID tongue could be a direct viral effect or an immune response, as indeed is we know this is the case with COVID-19. So here's data we've looked at a few times. This is from East Virginia Medical School. So we get this kind of the viral stage of the illness here, days 1 to 5, where there's viral replication going on. Here we get viral debris, but in this stage the virus is no longer alive. And here we get the immune dysregulation and the problems that can come as a result of the initial viral infection, as the immune system reacts in a way that we could probably describe as abnormal. Well, it is abnormal after getting rid of the virus. So really, once the virus has got rid of, the immune system should say, right, that's it, job done now. But we get this immune dysregulation that causes the problems. That's from the East Virginia Medical School diagram, which I find helpful. Right. So could be direct viral effect, or it could be the immune response. But that's true for everything related to COVID, so that doesn't tell us too much. That's like always true in COVID, really. Increased susceptibilities to fungal mouth infections, but don't seem to respond to antifungals. So it might not be that, it might be something else. So this might be a condition that looks a bit like this thrush infection, this manilial infection that we treat commonly. It might look like it, but it doesn't. It may not actually be a fungal infection. It might just something that looks like it. How common is it? Up to a quarter of hospitalised patients had tongue and mouth changes, right? So in the more severe disease, more cases. In the less severe disease, less common. That's why we have the COVID symptom tracker app with 1 million people reporting. We pick up these less common things. We don't know if it can be an isolated feature. When in the condition arises, does it occur early or late? And so that is now a question, and data is being collected on that. So for example, could it be a clinical feature that indicates that COVID-19 is present, and could that be the only symptom? Doesn't sound likely, but this is a strange disease, so that's possible. When in the condition does it arise early, in which case it might be a direct effect of the virus? Does it arrive after a couple of weeks? We don't know, but if it does arise after a couple of weeks, it could have been the immunological reaction rather than the virus itself, so data currently being collected on that. So that's a quick review of things related to the vaccine and COVID tongue, which is something that we're still very much learning about. But do remember that these are this deep venous thrombosis, pulmonary embolism, very common, very common condition. In fact, the fact that I just sketched that out like that must indicate that I've done this before and many times. And we teach this to all of our students all the time, and it is a common condition. So I would expect that the temporary prohibitions on the vaccination in these countries would be lifted. That would be my expectation. But it's delaying the programs in the meantime. Okay, that is us for this video. Thank you, of course, for staying with us till the end. It's quite a long one.